Hello, everyone. I'm Dr. Brian Wood from the University of Washington in Seattle. Welcome to the National HIV Curriculum Podcast. This podcast is intended for healthcare professionals who are interested in learning more about the diagnosis, management, and prevention of HIV. Dr. Jehan Budak is Assistant Professor of Medicine at the University of Washington in the Division of Allergy and Infectious Diseases. She is a provider at the Madison Clinic, which is our Ryan White-funded HIV clinic, and she serves as director of the HIV pathway through the internal medicine residency. She also serves as associate editor for the National HIV Curriculum. She is an expert in HIV treatment, HIV prevention, as well as general infectious diseases and many other topics. I'm also joined today by Dr. Raka Kumbhakar, who is assistant professor of medicine, also here at the University of Washington in the Division of Allergy and Infectious Diseases. She delivers care at Madison Clinic and at multiple low-barrier clinics for people with HIV or at risk for HIV, and she dedicates clinical and research time to improving outcomes across the HIV care continuum and to improving systems of care. Like Jehan, Raka is knowledgeable in many areas of general infectious disease as well, and is also a committed medical educator. And do I understand correctly, Jehan and Raka, you are also now co-assistant directors of the Madison Clinic?
That is correct. And we are sitting right next to each other in our teeny tiny office.
It's the glamour of co-assistant medical directors.
Our listeners won't be able to see that you are sharing an office, which I imagine is nice for consulting on cases, commiserating at times when things get challenging.
It's been super fun.
They won't be able to see our shared project agenda behind us on our shared whiteboard too.
And your shared whiteboard with the long to-do list, which I very much understand. Well, I'm really honored to be joined by you both today, and it's great that you're able to join from the same location, and this is going to be fun, and I'm really interested to hear your reflections on the scientific themes from what is arguably the most influential HIV-related conference each year. So without further ado, we'll dive in and talk about it. I'd like to start with just overall takeaways and themes from the scientific research you heard at the conference this year. Jehan, maybe I can start by asking you. I know you focused a lot on HIV treatment and ART studies and also paid attention to other things as well. But what did you take away as the major themes and trends from this year's conference?
I always look forward to the treatment topics, as I think you all know. And I'm always looking for is updates in injectable antiretroviral therapy for me, because that's what we're running here at our clinic. And I think for me, it's really always very helpful to see what are people doing that's new and sort of, I guess, corroborating what we're doing, seeing if others are doing what we're doing as well. And so I think there was a oral abstract that I'll be talking about, and then many posters actually that I found pretty helpful with regards to how to use CAB rilpivirine.
That's great. I believe we'll get into some of those in a bit more detail, but that's great just to think about overall trends and future directions. Raka, maybe I can pose the same question to you. I know you focused a lot on HIV-related comorbidities, but also other topics at the conference. What did you take away as the biggest trends in research and future directions?
Yeah, I think I was focusing a little bit more on comorbidities, as you said, and co-infections. And I think for me, that's really interesting because I think there's a lot of practical implications in our setting. I think when we think about co-infections, we're often looking at really great research coming out of sub-Saharan Africa or Asia, especially with regards to hepatitis B and TB. But I really try to think about how can I change my practice here in the US, in Seattle, which is a little bit different. And so I think there was some nice research in TB and hepatitis B, which I'll talk about today, and that I thought was really interesting.
That's great. Thanks for sharing that. And it really frames this nicely as what we want to focus on are the biggest areas of scientific research that may really change our day-to-day practice in clinic, offering care to people who have HIV or people at risk for HIV. So that frames this nicely. And Jehan leads me to the question, what did you take away as the biggest potentially practice-changing abstract that you saw at CROI this year?
So for me, I guess the one that I'll talk about is the CARES 96-week data that was presented by Dr. Kitio, which was abstract number 202. And so just to make sure that we're all on the same page, the CARES data, we actually first heard about the data from last year as CROI in 2024 in Denver, where they shared the CARES 48-week data. And so perhaps is a bit repetitive since people may be very familiar with the 2024 CROI results and findings. But the CARES was a big randomized trial that came out of Sub-Saharan Africa. That was an active controlled non-inferiority study of about 500 people randomized 1-to-1, either oral standard of care or cabrylpivirine administered every 8 weeks with or without an oral lead-in. And I think takeaway first is that it was non-inferior. Great. But I think the reason why, at least last year, things were so exciting was that one, this was a large cohort of individuals from multiple sites in Sub-Saharan Africa, in Kenya, Tanzania, and Uganda. It included 60% women. And at least in Seattle, that's not necessarily the epidemiology of the epidemic here. And so I think it's always helpful to see how the medication is being used with different populations. 50% of people in the CARES study had subtype A1 HIV virus. And this is a group of individuals who were very NNRTI experienced, which is worthwhile knowing, especially when we're giving people cabrylpivirine. I think the other thing that was key about the CARES study is that they used a public health approach. And so basically just the way I understand it is recruiting people into the study, getting people into the study, and there weren't necessarily genotypes obtained at baseline, and they were checking viral loads every 24 weeks or every 6 months, which again is different than what we do here, at least at the Madison Clinic. And so that was a 48-week data. That was a big recap of CROI 2024. I'm sure you're like, Jehan, focus on CROI 2025. And this year we had 96-week data that showed indeed that it is still non-inferior. And Brian, would it be helpful for me to talk a little bit more about the 96-week results?
Yeah, I think people will be interested to hear. What I've heard you say so far is there are some unique aspects in terms of who participated in this trial compared to who participated in the registrational trials that included individuals from North America. So a couple of unique aspects of who participated and a couple of unique aspects about how they monitored viral load and some things that make it just very different than the registrational trials here. So maybe we'll come back to why you think that's important. But if you could go on to summarize the key results, I think that'd be great for listeners.
One key thing is, again, as I mentioned, the results between the oral standard of care and the injectable arm were non-inferior, and the viral suppression rates were in the high 90 percentiles for both of them. And that was the same at 48 weeks and the same at 96 weeks. Whereas in the 48-week results, there were 2 virologic failures in the cabrylpivirine arm. At 96 weeks, there were 4 virologic failures in the cabrylpivirine arm. So for a total virologic failure rate of 1.6%, which I think is what we've been seeing. And then I think the other thing that was notable is that 81% of people in the study received their shots within the 7-day window. So that's a very treatment adherent group of individuals on a huge population level doing things in a public health approach. And so I think that's nice to see. And then also to, as we might expect based on our sort of clinical experience, based on the registrational trials, a large majority of people had injection site reactions as well.
So what would you say are the biggest takeaways or lessons from this abstract? And how do you think this might affect your clinical practice here in the United States?
One thing that, and again, sorry that this already happened in 2024, but was that from the 48-week data, when 50% of people had an A1 subtype virus, I think that was a big practice change for a lot of us. Whereas in the prior registrational trials for cabrylpivirine, such as in Atlas and Flare, we saw a lot of virologic failure amongst, the A6/A1 subtype. I think we kind of lumped those two together. And then now after CARES, I would say, I think most of us, at least I do, feel comfortable using cabrylpivirine in someone with an A1 subtype virus. And it's really just the A6 subtype virus that I'm a little bit still maybe worried or concerned about. And then I think the other thing too, and Raka can give me a hard time about this, but is the fact that, wow, people do well and people do fine not getting a viral load check every single day. I'm being hyperbolic, but like every month. They're in fact getting viral loads every 6 months and doing okay. And so I think that that is helpful. And I think will really make me feel more comfortable with potentially opening up the frequency with which I am checking viral loads here in our clinical patient population, at least for people who are virologically suppressed, because again, this was a cohort of individuals who were virologically suppressed.
Jehan, thanks so much. What I take from this and also adjunctive data about prescribing cabotegravir rilpivirine for individuals who maybe have a tendency to miss oral ART or have detectable viral loads is there is a lot of potential to expand use of this injectable therapy, potential benefits for people who are not currently receiving it, if we can surmount the obstacles to coverage and cost and procurement and all of the logistics. Maybe I'll give you the final word on this abstract before I turn to Raka and ask her a similar question. But what would you say about the current state of affairs in terms of simply trying to get injectable cabotegravir rilpivirine for people who may benefit?
Yeah, Brian, that's a great question. I think to your point, it has been difficult and there have been hiccups along the way with the rollout and implementation of injectable ART. And I think that we have seen some places do better than others, but nonetheless, everyone has some difficulty and there are logistical barriers through the roof, actually, with implementation of this. And so it is, to your point, that's such a nice way to put it, that when something can be done to scale, it can be done well. We can really get this medication to people who need it. And I think it is inspirational to see how this can be done and ways in which we can sort of take it to scale here as well.
Absolutely. Jehan, thank you so much. I'll switch gears. Raka, would love to ask you the same question. As you sat at CROI and heard a lot of really, fascinating research abstracts, what did you take as potentially the most practice-changing study you saw?
Yeah, I think I'll stick to a similar theme as Jehan in that it's really the longitudinal data from a study we've already heard a lot about, and that's the BEeHIVe study. So just to remind everyone, I'm reading it because it's hard to remember, B enhancement of Hep B vaccination in persons living with HIV. And so that was Kristen Marks's team. And this data has been presented many, many times, starting in 2022 at ID Week, I believe was the first time we saw data. And I'll go into the nitty-gritty in a second, but this is the 72-week durability data for the use of Hep B CPG. And I'll just say, once the brand name is Heplisav B, I'll say Hep B CPG or Try2 from here on out.
Sounds great. And I will try to do the same. It's challenging at times. So this is longitudinal, longer-term follow-up data. And Raka, maybe if you could remind listeners the design of the study and who participated, and then go a bit into what you see as the really key, potentially practice-changing results here.
Sure. Thanks, Brian. So basically, the whole premise is that we know that hepatitis B seroprotection in people with HIV is lower than people without HIV when they get conventional hepatitis B vaccination, which is with an alum adjuvant Hep B vaccine. And so what this study looked at and was really interesting was two arms. One was people with HIV who are hepatitis B prior vaccine non-responders. And then arm B was the Hep B vaccine naive group. And then within the non-responders, there's three arms. People got either 2 doses of Hep B CPG, 3 doses of Hep B CPG, or 3 doses of the conventional alum adjuvant. And then in the vaccine naive arm, everybody got 3 doses of Hep B CPG. People who were in the study were all people with HIV. They were on ART. They had to be virally suppressed. They had relatively high CD4 counts. So the inclusion criteria was a CD4 greater than 100. When we go in the data, the median was much higher in the 600s with a pretty high nadir actually in the 200s. People had to not have hepatitis B, obviously. They couldn't be pregnant. And people who were non-responders had to have a defined low surface antibody titer of less than 10. And as a reminder, 10 is our threshold for, and people who don't have a positive core antibody, that's the protective threshold. And that's basically who was in the study. And so just to recap, I think that was the second part of your question, Brian, of what has been all the stuff that's been presented before. And so in the non-responder arm, really the takeaway is everyone did better with Hep B CPG. And so in arm A, in the non-response group, people who prior didn't have a good response, superior responses with CPG as compared to alum, And if they got more doses, they had a higher surface antibody response. And I want to be careful and say higher and not necessarily say better, because I think that's going to be something we talk about. But people who got 3 doses of Hep B CpG were more likely to get a surface antibody of greater than 1,000. So remember that 10 was our cutoff, and we're up to 1,000 here. In the vaccine naive arm, arm B, all people with HIV who got the 3-dose Hep B CpG series got a seroprotective response, and 84% had that threshold of greater than 1,000. 99% had a seroprotective response after just 2 doses, though at slightly lower titers. But even then, a third got to above 1,000. So that was everything that's happened so far. I'll pivot now to what happened in this study. So again, this is the 72-week results. Basically, everyone still had a very durable response, but in group A, I'll say that at the end of study, who still had a surface antibody greater than 10, that was 97% in the 3-dose CpG arm, 86% in the 2-dose CpG arm, and a pretty dismal 57.5% in the 3-dose alum arm. So the other thing to note that among the people who achieved SPR, so the seroprotective response at any time in the study, but then lost it by study end, that was only 2.1% in the 3-dose arm, 10.7% in the 2-dose CpG arm, and 22% in the 3 alum arm. Then if I switch to group B, the end of study anti-surface antibody greater than 10 was 97% in the 3-dose arm, which was comparable to the 3-dose group in group A. And the durability now is 100% for primary seroprotective response, and then end of study seroprotective response was 97%. So I'll pause there because there's still some more data on durability, but I know that's a lot. And Brian, I'm curious if you have anything to add or ask in between.
No, that's fantastic. I do want to interject a question here. Rocket, seems overall to be very convincing data that Hep B CpG leads to much higher responses than the alum vaccines we used to use. So I just want to ask, in terms of translating this to clinical practice, to what degree have you switched in your practice to using the Hep B CpG? So
here at Madison, everyone is now getting Hep B CpG. Even from the prior data, pretty convincing that this is just going to get a better response.
So really 100% you have crossed over to using Hep B CpG for individuals with HIV, either who have never had Hep B vaccine and have an indication, or for those who have not had a seroprotective response to the older versions of the vaccine. Is that correct?
That's correct.
Okay. So maybe there, do you want to go into a bit more about the durability of response?
So what I've just talked about is that it's still durable at 72 weeks. Very few people who achieved their response lost their response. But I do want to highlight that the biggest takeaway to me was that the higher primary titers of surface antibody response were more likely to lead to end of study seroprotection. And so that was kind of the question to, I think, many of us is, does it matter if you get to above 1,000? And what we saw that 100% of those who had titers of greater than 1,000 at their primary response still had that end of study response. Now, the attrition rate may not be that dramatic as we saw, but I think it really is meaningful in thinking about what is our durability over time. And why does that matter? I think, you've heard Jehan talk about now cabrilpivirine. We're talking about a lot of switches to 2-drug therapies that don't have tenofovir in them. We know that tenofovir acts as a kind of hepatitis B PrEP. And so I think when we think about what's going to happen, do we just vaccinate and say, you're good to go for the rest of your life? We never have to check again. We never have to do anything. I think the jury's still out in terms of real RCT data about what it means clinically. But I think I'm pretty convinced it's better to get higher faster and then not worry about it.
Absolutely. So again, just coming back to clinical practice, sounds like you've really moved to only using this new version of hepatitis B vaccine. The other question I get asked a lot is 2 doses versus 3 doses, because there were 3-dose arms in the study. What are you doing in practice? Is there anyone for whom you are really encouraging 3 doses right now?
Yeah, great question. And I think this study, or this data rather, has kind of refined my stance, I would say. So I think that for most people, I've said 2 is enough. we have sufficient data to say that you're really getting high titers by 2 doses, especially if you have a high CD4 count. So I'll give the caveat that because we don't see people with pretty low CD4 counts in this study, that might be a population I might push to try to get 3 doses in to see if we can really get to a higher antibody response, since we know that might be less likely up front. I do think that there is a role for checking that surface antibody, which we do, and then making a shared decision with the patient and saying, you didn't really get quite up there. Let's try one more. I think it's really compelling to be able to say, hey, you can get 2 doses a month apart, and then you're set. And so for many, many people, I'm just saying that, check a surface antibody a couple months later, whenever they're next in, and say, I think we're okay. And maybe if they're switching to a 2-drug therapy, off tenofovir, I'll check again. And this is I'm making it up a little bit, but it might make me feel a little bit better.
Yeah, that point is very well taken. And it's a great reminder to think about hepatitis B status and serologies before considering a switch of ART, especially a switch of ART to a 2-drug option, and especially an option that avoids any version of tenofovir to an option that avoids TAF or TDF, for example. So then, Rocco, maybe last question, and I think this one is challenging because I haven't seen good guidance, but what if someone in the past had a level of surface antibody that was protective, and for whatever reason, it's rechecked and it has waned down to below 10, below the titer considered protective? May I just ask what you are doing in your practice in that circumstance?
Yeah, I know we talk about the amnestic response in hepatitis B, and yet we've had a handful of anecdotal cases, and I know we've had some here at Madison. Last time I was at the Ryan White Clinical Conference, I spoke to some people who had seen some reports of people who had lost that response and then acquired hepatitis B, again, off of tenofovir-based therapies. And so that to me is enough to say, let's just revaccinate. It can't hurt. And now at least I can say with Heplisav B or a Hep B CpG, 1 dose is probably enough to really rocket you up there.
So really a lot of convincing data for the benefits of Hep B CpG for practitioners who maybe haven't made that switch in their clinic yet. It sounds like what you are both doing in your clinical practice, Jehan. I've seen you nodding, which our listeners won't be able to see. And it really does sound like the data is convincing for the benefit over the older alum vaccines. So this is fantastic. We heard a lot about Hep B CpG, heard a lot about new data for injectable cabotegravir rilpivirine. So I want to thank you. We'll end this episode there, and I'm looking forward to another conversation about the important data from CROI. Thank you both.
Thanks so much, Brian.
Thank you.
Transcripts and references for this podcast can be found on our website, the National HIV Curriculum at www.hiv.uw.edu. The production of this National HIV Curriculum podcast was supported by Grant U10HA32104 from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the University of Washington IDEA program and do not necessarily represent the official views of HRSA or HHS.